Infectious diseases in the modern world, tonight on Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. Throughout history, humankind has often had to confront plagues. In today's world, where national borders and even oceans can be crossed easily, an infectious disease takes on a new and even more deadly specter. From influenza to Ebola, we're on call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. In 1976, the first case of Ebola was identified in Nizara, Sudan, along the Ebola River. Since then, there have been several outbreaks of this hemorrhagic bleeding fever. During this current outbreak, the CDC reports that as of September 16th, there have been 4,985 cases of Ebola, and that 2,461 people have died from this disease. The next worst outbreak of Ebola was in the year 2000 when 425 people died. This time, it's truly an international crisis. Joining us this evening to explore Ebola and other infectious diseases are Dean Mary Nedelman, Doctor of Physician and Infectious Disease Specialist, the Dean of the University of South Dakota Sanford School of Medicine. And joining us via Skype is Dr. Carlos Del Rio, physician of Emory Healthcare in Atlanta, Georgia. Thank you both for joining us. Dr. Edelman, tell us a little bit about you. Where are you from originally?
I was born and raised in Michigan.
City girl?
No, small town. A small town, about 10,000 people. My father was the family doc.
Okay. And then what happened after that?
Went to college, went to medical school in Tennessee, spent 10 years in Virginia, 10 years in Iowa, 10 years back in Michigan, and then I came here. So in between there, after college and medical school, of course, I did a internal medicine residency and an infectious diseases fellowship.
So and your infectious disease fellowship was where?
Indiana University.
So, and that kind of opened a bunch of doors about being a specialist with illnesses of all infectious kinds. I mean, and did you practice that, or did you go into administrative medicine?
Oh, no. I practiced infectious diseases for many years. I still see some patients, but not as many, and I enjoy travel and tropical medicine, which is why the Ebola epidemic is particularly interesting to me.
Great. And we're so grateful to have Carlos, who is from Emory, my alma mater. Carlos, tell us a little bit about yourself.
Well, first of all, thank you for inviting me to your program. I was born in Mexico and I grew up in Mexico City. I came to Emory in the early 80s to do my medicine residency. And I came to Emory primarily because I wanted to be a cardiologist. As you know, Willis Hurst was the chair of cardiology here, and this was a great place to do cardiology. But I started my internship in July of 1983, and that's when we started seeing patients with HIV, and it was really starting to see those patients in the fascination of a new disease that got me interested in HIV, got me interested in infectious disease. So I went on to do an infectious disease fellowship.
Now, Ken Walker, who has been on this show and came from Emory, also said to me that you had then gone back to Mexico for a period of time in a leadership position. Tell us about that.
Yes, at the end of my fellowship in 1980, I guess must have been 88, 89, I was going to start doing EIS at CDC, joining the EIS program at CDC, but a good friend of mine, Dr. Jaime Sepulveda, had just been appointed the Deputy Assistant Secretary of Health in Mexico, and he invited me to go down to Mexico and to work with him in starting the National AIDS Program and into developing the National AIDS Program down there. So I spent the next 8 years of my life in Mexico with a combination of seeing my own patients, but also having my practice, but also working with the government in a variety of different programs, and most particularly in the HIV and the STD program. I came back to Emory and joined the faculty here in 1997.
So in the Annals of Internal Medicine, there was an article about Ebola, and you were the lead author. Tell us a little bit about how that happened, quickly.
Well, you know, it's interesting. It happened in a very funny way. Nowadays, it's a very interesting world. I was actually in Mozambique, in Maputo, and I was arriving in Mozambique for a meeting of, there's a grant called MEPI, Medical Education Partnership Initiative, that it's funded by the U.S. government to improve medical education in sub-Saharan Africa. And I was there for the MEPI PIs meeting, and I received a message through Facebook, and one of the deputy editors of the Annals of Internal Medicine was a good friend of mine, Debbie Cotton, sent me an email saying, hey, you know, we know that there's cases of Ebola happening right now. There's Ebola cases at Emory. Would you be willing to help to write an opinion piece for us? The ideas and opinion pieces for the Annals are about 1,000 words, no longer than that, and about 10 references. And I thought it was a great opportunity to review a topic of which I have a lot of interest. I teach an international infectious disease course here at the School of Public Health at Emory, and we spend a lot of time talking about hemorrhagic fevers and other diseases like Ebola. So I took the opportunity. So it's the first time I've been invited to write an article via Facebook.
This is a great article. We'll learn more about your connection with the people at Emory who took care of the doctors that returned from Western Africa in just a minute. Humankind has dealt with plagues and pandemics since the beginning of time. Let's look at 10 of the major outbreaks from history.
Top epidemics of all time. Number 1, polio. As recently as 1952, there were an estimated 58,000 cases of polio in the United States alone. 1/3 of the patients were paralyzed. Of these cases, more than 3,000 died. Number 2, typhus. Given its frequency among encamped armies, it was often dubbed camp fever or war fever. During the course of Europe's 30 Years' War from 1618 to 1648, typhus, plague, and starvation claimed an estimated 10 million people. Yellow fever is number 3. This illness, also known as yellow jack, ripped through the colonies, decimating farms and even major cities. Number 4, AIDS. The emergence of AIDS in the 1980s has led to a global pandemic, killing an estimated 25 million people since 1981. Number 5. For decades, it seemed cholera was a thing of the past, just a disease of the 18th century, bested by improvements in sanitation and medical science. In 1991, cholera sickened an estimated 300,000 people and killed 4,000 within the year. Number 6, tuberculosis. Beginning in the 1600s, the European TB epidemic, known as the Great White Plague, raged for 200 years, killing approximately 1 out of every 7 infected people. Number 7, malaria. Each year, between 350 and 500 million cases of malaria occur. Of those cases, more than 1 million result in death. Even in the United States, more than 1,000 cases and a handful of deaths occur each year, despite previous claims of eradication. Number 8, the Black Death. It is believed that the Black Death killed 1/3 to 1/2 of Europe's population in 1348 and also decimated parts of China and India. Number 9, the flu of 1918, also known as the Spanish flu or the Great Influenza. The disease killed as many as 20 million people in a matter of months. The global death toll reached between 50 and 100 million fatalities. 10. smallpox, brought to the Americas by Europeans in the early 1500s. At that time, there were approximately 100 million Native American people. During the epidemic that lasted hundreds of years, smallpox and other diseases decreased that number to 5 to 10 million.
Well, that run-through of 10 was just fabulously interesting and really very sad. I mean, what was your thought, your response to that, Mary?
Well, I think, I think that the last point is one of the most telling points. The proportion of deaths, even today, that are still due to infectious diseases. We often don't think about it, but in almost every war, infectious diseases have killed more than bullets have.
Some of the, what did you think about that, Carlos?
Well, my take was that a lot of these diseases cause many deaths in our country, in the United States. Yellow fever was a major plague of malaria. The CDC exists here in Atlanta because this was a malaria endemic area. And I think we have been able to eliminate a lot of these diseases. We have been able to eradicate smallpox from the world. We're very close to eliminating polio. So I think I also see a message of hope that an infectious disease, we've had tremendous advances, and a lot of it has been through development, through investment, through sanitation, and yes, through vaccines. So I really think that there's also a message of hope that a lot of these diseases that are currently still affecting countries shouldn't be there if we had done the right things in public health.
Yeah. Still, a lot of people do die. I mean, cholera, for example. I mean, or in developing countries where water hygiene is the
Well, and
major.
a lot of people get cholera, but interestingly, there are a lot of simple public health ways that we can reduce the mortality rate from cholera, that we can, giving people clean water, of course, is the number one thing, but rehydrating people appropriately. We know a lot about how we can reduce the death rates further, even when we do have these diseases now.
The problem is you've got to have the water to give to them, and they've got infected from it in the first place. I mean, just think about a replacement. You have to pour the water down them to keep them from dying from dehydration. And so water is such an issue. I love the story of all of the infections that occurred in the settlers that were coming across the U.S., and they would come to another place and they didn't have an established water source, and then they would all get sick and many would die. And during that same time, the Chinese came over and they didn't die. And they seemed to survive, particularly when they were making railroads. And they didn't die because they were drinking tea.
They
boiled their water. And of course, a lot of their teas were quote unquote curative and healthy stuff. Well, it was because they boiled their water. Carlos, anything about Mexico or what's happened in Mexico and water supplies and issues that still are wrestled with down there?
Well, again, during the time that I was in Mexico, we had case of cholera. A case of cholera came into the country after, remember, in the early 90s, there was an epidemic of cholera that started in South America and Peru, and those cases came into Mexico. But that led the then Secretary of Health to really make a major effort to chlorinate the water and provide clean water to people by adding chlorine to the water to the water supply, and that really brought the epidemic under control fairly rapidly. It was amazing. You couldn't drink the water; it tastes horrible and it looked dark. But cholera was no longer there. So again, public health is fantastic when well implemented and well done, and that's a challenge that we're facing right now. For example, with Ebola. We say, I've been talking to a lot of people that are in Liberia and other countries. They say we don't have in the hospitals water. We don't have simple things to take care of the patients. It's going to be very hard without that infrastructure to actually control the epidemic that otherwise would have been very easy to control.
Go ahead.
And when you think about it, the hospitals are under incredible strain, not having supplies. And many of these patients are being taken care of in homes, which have even fewer supplies. So it is a public health issue. So
the president just announced that he's sending over Army troops to help in the 3 or 4 countries that are involved. Do you sense that they could help because they could bring supplies, or they can control panic, or where's the advantage?
I think that the key thing is we're sending over supplies, right? We're sending over supplies to help isolate people. We're sending over gloves, and we're sending over kits, and we're sending over mobile hospital units. Somebody has to deliver those and put those all up. In the past, in the remote past, we've had many things where we've put a lot of supplies into the capital city and it's never gotten out. So you need a distribution network, you need somebody to help set things up, and I think that's what the personnel are probably going to be for.
Right. Right now, though, if I were a Doctor Without Borders, a volunteer, and I said, yay, I'm going to go help these people, I charge in, I don't have supplies, and then suddenly I'm isolated, I can't get out if I want to run. I mean, it may not be a very good scenario for me over there. Think about the trouble of the people who go there to help and then can't come home.
It's interesting. The CDC actually has a course they're putting on, and maybe Carlos can speak to it more, but for healthcare workers who are planning to go over to Ebola-affected areas, and they're putting it on every week. I don't know, Carlos, if you know more about that, but it's on the CDC website.
There's a course that CDC is putting together for people who are volunteering, and they make it very clear that they're not deploying people. They're simply people that are volunteering for other organizations like Doctors Without Borders or Partners in Health, and they're willing to provide the education. Because again, from the experience of talking to my colleagues here at Emory that took care of the patients here, one of the issues, for example, is not just talking about personal protective equipment. You really need to know how to use the personal protective equipment. It's not just about what you need to do. We actually need to be trained. So the training that is necessary, I think this is what the CDC course is going to be doing.
Carlos, tell us a little bit about the friends that you know who have cared for the people that came to Emory. And I know that there's some doctors who've come over not only to Emory, but to University of Nebraska, I think. What risks are these people taking by having the people come into their hospitals?
I think as far as risk to the hospital and to them, it's very little. We have our hospitals in the U.S. have the necessary infection control practices and infection control procedures that we can take care of patients with diseases like Ebola without much difficulty, because again, we have supplies, we have disposable equipment, we don't realize all the good things we have that allow us to contain and to take care of those patients. I think the challenge really is that these are 2 or 3 or 4 patients that have come to this country, and the real challenge is the patients that are in these other countries where thousands of people are going into hospitals, and simply the hospitals are overwhelmed. And you and I would probably not call many of them, we would probably not even call many of them hospitals because they don't have the necessary supplies, they don't have the necessary equipment, they don't have water, they don't have sanitation, and that's a challenge. The challenge is how do we implement what we know about control of this kind of infections in a setting that is very difficult to deal with.
Mary, I think there's a certain panic level that people can have with epidemics. Mm-hmm. And I know that all humans, I just think about the panic that would occur back in the plague time when they had no idea what was causing these illnesses, and they blamed everything from guilt and to anything else. What about panic here? Do you think that there could be, if Ebola did occur in the U.S., could be panic? How do we counter it? Is it justified?
Well, and I think Carlos is right. I think that the risk of having several Ebola cases suddenly introduced in the United States is not as much from the spread of Ebola, because we can, with public health measures, contain it. It is the panic and the concerns. We have dealt with many pandemics in this country. We usually get our act together after the first little bit. I remember the first cases of HIV. People were really quite petrified of the entire thing, and people were ostracized, not isolated, ostracized, right, or even discriminated against. So it might take a while to, have everybody believe the truth with this, that really you can isolate these people effectively, and really there are a lot of things we can do that would limit or eliminate the spread of this disease.
Right. Let's talk about SARS. I mean, that makes me think about SARS. Carlos, any comments about SARS that you would like to make sure?
I mean, I think SARS is a lot more concerning, right? SARS is transmitted through the air, and I think that makes it a lot more difficult to contain. If somebody with SARS comes into the emergency room, and happened in Toronto and happened in other places in developed countries, there was a lot of transmission because it's an airborne pathogen versus Ebola, which is a bloodborne pathogen. So I think that makes a huge difference. A lot harder to control something like SARS, and yet we were able to do it. A lot harder to control something like pandemic flu, and yet we were able to control it. So I think that the challenge is, as Mary says, is the panic, is the unknown, is what people think. And we have to remember that after 2009, during the pandemic influenza, that was really, I mean, in the last several years since anthrax, we really have moved into pandemics now being in 24-hour news. They have moved into an area where there's always talk in the press, there's always talk in the television and the radio, where there's people in social media talking about diseases. And as much as there could be great programs like this one giving the right information, there's also a lot of information out there that is giving exactly the wrong information, and that's creating panic. So we have to balance those things, and I think the challenge is, how do you do it in a time of a lot of crisis? And you do it by just staying ahead and continuously giving information, continuously communicating, continuously being out there telling what you know and what you don't know, and what you're doing to try to control the disease. I just sent you a link through Skype message to the CDC course that Mary mentioned. If people want to see it, you can distribute that later in your program. There's actually the web link to that course.
Okay. SARS, explain what it is, Mary.
Well, and really what it was. It was a respiratory illness. It was spread rapidly from person to person. It affected healthcare workers. It had a high mortality rate.
Like what? 20%, 40%, something like that?
Mortality rate, I don't remember the number exactly, but it was in the 40% range, I'm thinking. So it was rapid, it was virulent, it was fatal, and it spread from China and in Asia and started going right through the global networks. And it was stopped by plain old public health measures if the people were sick, they were not allowed to go outside, right? Healthcare workers wore protective masks when they took care of people. And this is this could have been, actually this was the greatest public health triumph in my mind of the recent decades by far. And it's maybe not quite up there with wiping out smallpox, but this would have become the smallpox of our time. This was going to really come and get us, and it was just stopped. So I think this has been a real amazing success. We were all so gearing up in this country, and we owe such a debt of gratitude to the CDC, of course, who helped with things, but also the public health authorities in all the countries that dealt with it.
So, and where did it end? I mean, was it up in Canada that it stopped?
From our standpoint, it ended in Canada. There was, if I recall right, there was a laboratory strain that got briefly loose later on that was then destroyed. But it was an interesting virus.
Okay. So, Carlos, any take-home messages about SARS? And then we'll take a break.
Oh, I think a huge take-home message about SARS, and again, happening in Ebola, is that the most heavily affected individuals were healthcare workers, right? It spreads in the healthcare setting. I was reading an article in Science the other day about Ebola, and it struck me that 5 of the authors of the article had died as a consequence of dealing with the disease. So again, we're dealing with a disease that it causes not only these countries have deficiency of healthcare workers, but also the few healthcare workers are then being affected because they don't have the personal protective equipment. So the impact on healthcare workers is something that we should not forget about diseases like SARS or Ebola.
Oh, I think about the heroes that are over there taking care of people right now. I mean, the Doctors Without Borders.
Right.
Many of us would have to think to find Sierra Leone on a map, but it is an African country that has been devastated by Ebola. One South Dakota State University student from Sierra Leone gave us a personal insight into life there and a way in which we may help.
I got in contact with some key people in Sierra Leone, like the Minister of Health, the Chief Medical Officer, some key doctors and obviously just friends and other relatives found out that they needed medical supplies to protect the healthcare workers. And so I relayed that information to Global Links, and they are basically helping to provide health workers with these kits. There are people in Sierra Leone, at every level that are trying to make a positive difference. Sierra Leone does not have the infrastructure that the United States has. Healthcare largely is based on if you have money, the more money you have, the better the healthcare you can receive. Again, you have a lot of private hospitals. You have the government hospitals are pretty much jam-packed with patients and very limited resources and supplies. Really, if you're rich or you have some money, then you're more likely to receive better health care. I have very close cousins, aunts, nieces, nephews that I'm very close to. They're there. My identity is Sierra Leone. I grew up there. I have friends that are there, and just getting updates. My very close friend lost her mom. She's a doctor. Lost her mom to Ebola a few days ago, and her house has basically been quarantined because she's been exposed. Her dad's been exposed, and so it's a difficult thing. It's basically taken over the whole country, and I would like to see a situation where people have a fair chance to life and fair chance of living without so many issues. I want people to know that obviously Ebola is something that is very difficult, and I'm not wishing that it's a world problem, but it is potentially a world problem, and I want to encourage people that are in the position to make a difference or to help in any way to do so.
Thank you, Christofina. The personal story is amazing. It's interesting that the death rate is something like 50–60% in this awful virus. Mary, tell us a little bit about this particular Ebola virus.
Well, it's as we said, a virus, and it's a very special type of virus. And up until now, it's been an unusual virus, causing small outbreaks of limited size in Africa, to the best of our knowledge. It is a virus that it doesn't seek out humans necessarily. Its natural reservoir, if you will, are probably other animals like the fruit bat, the fruit bat, right? Who doesn't seem to get very sick from it, but secretes it in its droppings or partially eats fruit and drops it. Other animals might eat that fruit, get infected. People may eat that meat, or they may eat the partially eaten fruit. And so it's interesting that the animal to human transmission doesn't occur maybe super often. It's the human to human once that happens, though, the human to human transmission is where we have our problems.
Right, particularly cleaning. The tradition of cleansing the body of the dead person had to be changed, because that's the way that people would get it.
And we're hoping it's being changed, but once Ebola gets into the system, nothing happens for days to even up to 3 weeks, and then people get what feels like a bad flu, a headache, muscle aches, bad diarrhea, a cough, and then everything goes to heck in a handbasket, and you end up with people with multi-system organ failure.
Do they bleed to death? Is that what really
not
kills
usually.
them?
It affects the clotting system, and it goes haywire, so people bleed. They don't usually gush. They more ooze from just about every orifice. Some people don't bleed at all. So it has a spectrum of disease.
And
after,
the blood pressure drops. And
yeah, blood pressure drops.
Organs die.
And the organs die, or about a week later, some people start to recover. And this virus also pushes down our own immune system, pushes down our ability to respond. So you're almost defenseless when it comes upon you.
All right. Carlos, any thoughts that you would have on what Mary said?
No, I think Mary reviewed the pathogenesis of the disease very well. I think that one of the things that clearly we also don't understand is how severe the mortality of the disease is, because we're talking right now about 40, 50, 60%, but that's in the setting of no healthcare system, which is they have in Africa. If we had those patients with healthcare, we were able to provide supportive care, hydration, fluids, transfusions, the mortality may be 5%, 10%, and we really don't know that. And that's something that we learn as the U.S. military puts these medical facilities where they can actually provide the kind of care that these patients really need. But clearly, what Ebola is showing us is this huge problem that we have with not having healthcare systems in many of these countries. This one thing that brings together the three affected countries, Liberia, Sierra Leone, Guinea, is they are some of the poorest countries in the world. You're talking about countries that are incredibly, incredibly poor. So poverty, lack of healthcare, lack of infrastructure. As the student said, in my country, healthcare is something that you get if you have resources. If you can pay for it, you get it. And that obviously is, I think, what we're seeing right now is the consequences of the lack of investment in healthcare infrastructure in many of these countries. That unfortunately now we have to go back and fill the hole, and that's going to take some time.
So I've heard that they're on the verge of having a vaccine. They're on the verge of having an antiviral Ebola medication.
On the verge is a generous term there. I mean, there are vaccine candidates that are undergoing some testing. They've been tested in non-human primates, and the CDC, the NIA, everybody's moving those along, but we don't really have something imminent, unless Carlos knows something I don't about that.
No, we don't. I mean, we really don't. It's they're being developed, and they're going to take some time. But the things we can do to stop it right now are things we actually know how to do. Personal protective equipment, water and sanitation, hydration, patient support. Those things we can do. In the meantime, yes, developing a vaccine is going to be scientifically very important, and developing a treatment is going to be very important. But again, when you think about the treatment, I think you have tremendous ethical implications. Most of the time when we're doing a clinical trial, you want to provide a minimum standard of care, right? What is the minimum standard of care you're going to be providing when you do this clinical trial? No care, some care, So again, doing the clinical trial in the current environment is going to be incredibly hard.
I heard of late that they had the serum of a man who had survived that they were transfusing into another person. Right. What do you know about that, Mary?
Well, this is something I believe a WHO panel thought that this was at least worth a shot in the desperately ill. After somebody recovers, they make antibodies. So if you take their blood, you can take the antibody and put it into somebody else. You have to do that really right. We don't know if that will work, but you have to do that right. Remember, you're taking blood from a person who's had Ebola. First of all, you want to make sure that there's no Ebola there. There are no other bloodborne pathogens like hepatitis or HIV. And it would be really, in my mind, best to do this under experimental conditions so we could really see whether or not this is having an effect. But I just said it suppressed the immune system, so this is a way to give the immune system back. Sounds like a good idea. Really, we've had these things sound like a good idea. If we're going to do it, we really just need to follow it and test it.
All right. We have a map.
That brings up a very interesting point, is that in I think it was 2009, there was a very interesting paper published from Gabon in which they looked at seroprevalence of Ebola in the general population. They looked at adults that had never had evidence of ever having had Ebola clinically, and 15% of them had antibodies against Ebola, which makes you think that there are probably some asymptomatic cases, that not everybody that gets infected develops the disease. And I think, again, we don't know enough about the natural history of the disease to really know what the consequences are.
There was an OBGYN that was not in any way involved with people who had the disease and came down with it. My guess is that somebody had the infection, but was asymptomatic and was delivering a baby, and that's what he did.
Or, I mean, if you're asymptomatic, you're usually not contagious. It takes a little, after symptoms even, it takes a few days for the virus to really peak. But somebody who just had a fever and was sick, and certainly delivering a baby would be one of the things. The other way you can get it is, as Carlos was saying, is if you're in with a patient with Ebola and you're covered with all their goop, and you go out to take off your gloves and your gowns, and you don't want to just take it off and rub it over your hands as you're doing it and all that sort of stuff. It's not only how you put it on, it's how you take it off. So there are a lot of different ways to come into contact with it. I think you're right.
All right. The Enterovirus D68 is taking the nation by storm, infecting people in at least 10 states. South Dakota State epidemiologist Dr. Lon Keitlinger visited with us earlier this week about this newest outbreak.
So let me say a few things about this enterovirus D68. And this is as of today, I'm talking on the 16th of September. We have 104 people who are confirmed with it across the United States in 10 states, not South Dakota. Some is nearby as Iowa and Illinois. And in fact, Illinois and Missouri is where the first outbreaks were detected and confirmed. But the virus is probably more widespread. Here in South Dakota, we are doing testing. We have to send the tests to the Centers for Disease Control Laboratory in Atlanta, and we've sent 22 specimens from 18 patients as of today down for testing. Hospitals in South Dakota, they can test for the routine or the normal or the run-of-the-mill enterovirus, but not this specific D68 strain, which is heretofore it's been fairly rare. This strain has been known for over 50 years, since 1962, when it was first described here in the United States, and there have been little detections of it and little outbreaks periodically throughout the years, but this seems to be the biggest one and the most widespread. In fact, there are 100 different types of enterovirus that have been described, and every year it's common. There's 10 to 15 million infections of these enteroviruses across the country. So what we're dealing with now is just a specific substrain of the big enterovirus family, which is this D68 strain. And what it causes is a respiratory illness, runny nose, coughing, sneezing, fever, muscle aches, body aches, and for most people, it's a very mild disease. However, for some children, and this disease hits children, it can become very severe, especially children with pre-existing asthma. These are the children that are most prone to develop severe respiratory illness. It's transmitted, it's a respiratory illness, so it's transmitted in our saliva, snot, and sputum. So the virus from one person, when they cough, it can be coughed out and another person gets it, or it gets on somebody's hand or somebody's surface, and then another person touches it and they bring it into their mouth or their eyes or their nose, and they become infected. There's no vaccine for this viral disease, so the only way we can prevent it is just by good hygiene. Wash your hands with soap and water often. So if you're touching something that, unbeknownst to you, was coughed on by an infected person, you don't bring it up to your eyes and mouth. So don't keep your hands away from your eyes. And then if somebody's sick, avoid kissing, hugging, and snuggling with them. And as always, disinfect surfaces that are in daycares and schools, and especially places where children gather. Disinfect the toys, the surfaces, the doorknobs, the keyboards. Keep them as clean as possible. And even though there's no vaccine for this virus, there is the vaccine for the mother of all respiratory diseases, and that is influenza. In fact, influenza vaccination is now widely available across South Dakota, and now is the time to get it. Don't wait till December. Don't wait till right before Christmas, but get it now. We don't know when influenza is going to strike.
I can see that Lon is against kissing and snuggling. I don't know if that's how you feel about it. Down in Atlanta, do they kiss and snuggle, Carlos?
Yeah, probably not as much as in other places, but people clearly there's still some kissing and snuggling, but I think transmission of many diseases occurs through respiratory secretions.
Right. How worried should we be about this?
And you got to remember that children are specialists in transmitting diseases.
They snotty, hands everywhere.
You gotta hug a kid.
You gotta hug the kid, right? That's how grandparents in particular get it. So this is a bad illness, and do you have particularly important messages about preventing the spread? And
Influenza or Ebola?
well, both. Well, no, I'm talking about the Enterovirus D68.
Oh, the Enterovirus. Okay, the Enterovirus D68. Yeah, I mean, this easiest way is exactly what Dr. Keitlinger was saying. Wash your hands, cover your coughs, wash your hands again, and just use good cough etiquette. And the same thing you would do in flu season is usually the best thing to do for us.
Carlos, he pushed the flu vaccine, and of course, I think that's an important issue. Where's your take on the flu vaccine?
I think the flu vaccine is a vaccine that is not a very good vaccine, but it's the best vaccine we have to prevent influenza. And there's plenty of studies that show very nicely that influenza morbidity and mortality is decreased by the use of the vaccine. So I'm a big believer in the vaccine. I vaccinated myself. I vaccinated my family every year. And I think that it's a good thing to do. It's a good intervention if you want to avoid getting the flu. I personally have gotten the flu. I've gotten the flu, virologically proven flu, and it's no fun. So it's getting the vaccine. It's a minor nuisance for the possibility of avoiding several days of work and being quite ill.
Right, and some of us who have respiratory tendencies and allergy kind of illnesses like I do, once I get all fired up with that thing, it's a long time to come out of it. Well,
and there's a mortality rate every year. I mean, mortality in this country is seasonal, always has been, and it follows the influenza season. So I'm a big believer in the influenza vaccine as well.
So it's interesting, we're talking vaccine, and pneumonia vaccine is another issue, and I think people ask a lot of questions about pneumonia vaccine, but it was interesting to read in the New England Journal that they said that the Prevnar pneumonia vaccine in children saved more elderly people's lives than anything else. Explain that.
Well, and this same thing is true of influenza. When we start vaccinating children, right, maybe that the old people are more likely to die of the disease because they're reaching the end of their lives and their organs aren't working as well, but they go hug their grandchildren and they go play with the young kids. And so they're getting it from these little influenza factories that we keep producing, or these little pneumonia factories. Yeah. So one of the ways to interrupt transmission is to vaccinate this population. And of course, there are other reasons to vaccinate children as well, but that's one of the reasons why vaccinating children reduces diseases, seasonal diseases in adults.
Carlos, there's a lot of concern about vaccination in the children, though. I see people going through every kind of way to either avoid it because they feel that there is a risk for this or that, polio, or the next thing they're talking about is neurologic deteriorating diseases or so on. What do you sense about the true risk of vaccinations in children, and is there a reason why we would? Well, let's take that question first.
I think the true risk, Rick, is not vaccinating children. We are seeing a resurgence of diseases like measles, like whooping cough, like many other diseases in this country that we hadn't seen in years because we have parents now unwilling to vaccinate their children. And that's a problem. That's a significant problem that vaccine preventable diseases go away because you have vaccines, and until we have eradicated those diseases, we need to continue vaccinating because there's populations coming in and out, and to have a immunologically susceptible population could be a problem. And some of these diseases can cause significant illness and can even cause mortality. And we've seen in the past couple of years several small outbreaks of measles, of whooping cough, of many other diseases that, again, are vaccine preventable and are due to the fact that we have these pockets of individuals, of families, of other individuals that unfortunately are usually from high socioeconomic strata that have decided that vaccinating their kids is not a good thing to do, and that's a problem because there's really no evidence of the harm that they're proposing on vaccines, and on the other side, there's a lot of benefit from the vaccines.
Mary, explain the reasons why people wouldn't vaccinate their children. I mean, think about the benefits to the kid, but also think about the benefits to our society and our older people who would be exposed to these children.
You know, there's a term actually coined called vaccinophobia. There have been a couple charlatans, a couple real people I consider to be some of the most horrible people on earth, who put out fake data. There was a person who was in England who did this, and fake data, and put out fake data about vaccines causing things like autism. The data was fake. The story lives long on after it was shown definitively to be false. And so, you know, it raises a doubt in people's minds, and so they don't vaccinate. I vaccinated my son, and I certainly would do it all over again. I know what these diseases do. If there was a vaccine against Ebola that was effective, we'd all wonder why somebody wouldn't take it.
Right.
And yet, you know, it may be that we've just forgotten what these diseases did, because the people who are alive today, us, right, we're the ones who survived the childhood diseases. The people in our our parents' generation, and even in our generation, who died, they're not here to say, no, I'd rather have been alive.
Yeah.
So I think it's a multitude of reasons.
There was a movie not too long ago called Contagion, at which time we saw this horrible destruction of our modern society. And my sense is, and I've heard it before, and I feel that it's probably true, that there is a potential for some kind of horrible epidemic that could occur in developed countries. Carlos, do you have a sense of that, and what would be your comment about my Contagion movie?
Well, I think the movie is it's a fairly good movie. I think the movie really depicts a lot of the panic and the anxiety that occurs, as Mary was saying, during an outbreak and not knowing what's going on. You know, we saw a little bit of that during anthrax. We saw a little bit of that during pandemic influenza. If we had a major outbreak in many of our countries, we would see that panic occurring. We were, you know, very concerned at some point in time that maybe terrorists had smallpox, and that would be another concern. So again, people are worried, and infectious diseases can spread very rapidly in a population and can really cause pandemics of unprecedented proportions. So we need to be alert. We need to have, I think that reminds us how important it is to have strong public health, how important it is to have surveillance, how important it is to have people dedicated to looking at these diseases, to implementing programs to control them, because we really don't realize how fortunate we are to have the public health infrastructure we have in this country that has allowed us to really improve the quality of life and decrease our risk of getting many of the diseases in an incredible way. But again, as we cut here and cut there, and we don't need this and we don't need that, we run the risk of destroying our public health infrastructure, and that could have consequences of starting an epidemic at some point in time. We have other risks, of course, and that is, for example, the risk of multi-drug resistant infections, multi-drug resistant tuberculosis, multi-drug resistant bacteria. And again, there's always epidemic risk. What I would say, you know, Mary's there and I'm here. I think the world needs to be glad that we have infectious disease physicians.
Yeah. And I
like that.
Hey, and I'm not an infectious disease guy, and I'll say that.
I think you missed your calling, though. You seem to like this.
Oh, yes.
Yeah. Mm-hmm.
So, quickly, talk about the first case of Ebola, that story.
Well, in the New England Journal, very recently, there were investigators who traced back the cases of Ebola, and they interviewed people. They looked at hospital records. They also looked at the genetic typing of the virus that has already been gotten. And they traced it back to the first case they could find, which was a 2-year-old boy in late 2013 who died of an illness that had all the features of Ebola. And then his mother, who took care of him, died. His sister died, and then the grandmother died. People came from far and wide for her funeral. They were on the border between these countries. And then, you know, and they helped prepare the body, and they interacted with each other, and then they went elsewhere. And the authors were able to trace several clusters that came from there, clusters that came from that, and clusters that came from that. Now, there are probably lots of cases of Ebola that we haven't diagnosed, and that's So it's just an interesting person-to-person transmission.
But the very first story, and then you watched how it spread. Well, this is an important lesson. We've got a few seconds. Any particular comment about that? Carlos, any comment you want to take?
Well, I think just for your viewers, I think the important comment is that we need to think that as far away as West Africa is and an ocean away, it's right here, and we need to be aware that there's a major crisis happening there. And I applaud people that have gone there to volunteer, but you can also, there's two things we need. We need to volunteer, or we need to donate money in order to control this epidemic, because we cannot go to sleep and be comfortable that everything is fine in the world as long as that epidemic is ongoing in West Africa.
Wonderful words, Carlos. We'll be right back after this.
When you smoke, so does your baby. If you smoke while you're pregnant, you're putting deadly poisons into your blood. The same blood you share with your baby. It can damage babies' lungs, cause premature birth, underweight babies. Plus, babies of moms who smoke are up to 3 times more likely to die of SIDS. Please, quit before it's too late.
It was in London, England, 1854, when a severe diarrhea illness caused the deaths of 500 adults and children over 10 days. Physician-scientist John Snow, mapping out the locations of those sick, realized that the cause of illness might be from the well water coming from a hand pump on Broad Street, and he convinced authorities to shut down the source. After removing the pump handle from the Broad Street pump, deaths abruptly slowed down. And this helped bring the city, and then the developed world, to realize the danger of contaminated water. Over the next years, scientists identified cholera, or Vibrio cholerae bacteria, as the cause of that illness in London and elsewhere. The original pump is still there on what is now Broadwick Street in London, commemorating what is thought to be the founding event in the history of epidemiology, the science of understanding epidemics, infections, and patterns of illnesses in populations. The word cholera comes from the Greek word chole, or chole, which means literally bile, from an ancient and, of course, wrong idea that all illness is from an imbalance of bile and phlegm or blood. It's interesting to note that years ago, many ill-directed physicians thus treated various illnesses by bleeding their patients or inducing diarrhea. Of course, there are many causes for infectious diarrhea, including viral, bacterial, and parasitic causes. We came to realize after the mid-1800s with the newly discovered microscope how to categorize bacteria, and that cholera was likely responsible for many of the pandemics throughout history. Sadly, despite all our present accumulated knowledge, cholera persists today in developing countries, mostly the result of polluted water. Cholera is an acute diarrhea illness that can kill within hours if left untreated by causing nausea and vomiting, along with 3 to 5 gallons of rice water diarrhea per day, resulting in severe dehydration of an individual. Unfortunately, highly infectious fecal material can too easily get into the water supply or food, spreading the infection, especially to the very young, old, and immunocompromised. More challenging is that 75% of people infected with cholera may not have symptoms, but carry the bacteria for 2 weeks after exposure, increasing the spread. Sanitation methods could prevent it. Rehydration therapy and antibiotics could treat it. But too often, these interventions are not available in developing countries. The World Health Organization, an arm of the United Nations, estimates that 3 to 5 million cases and more than 130,000 deaths each year are still due to cholera. This time, the problem cannot be resolved by simply removing a pump handle. So tell us a little bit about what's happening at USD School of Medicine, Sanford School of Medicine.
Well, that's a whole talk in itself. But pertinent to what we've been talking about is that we have started, as of January, we will start a Masters of Public Health. And as we talk about public health here, and this is a joint with SDSU, as we talk about public health, this is something we should do.
Carlos, 10 seconds for a take-home message.
I couldn't agree with you more with Mary. We at Emory are fortunate to have a school of public health, and about 25 to 30 of our medical students do an additional year to get a joint MD and PhD degree, and those students really leave with an understanding of not only individual health, but population health. It really transforms the ability of those students to then be better doctors in the future.
Fabulous. Well, this brings us to the end of our show this evening. I sincerely thank our fantastic guests tonight, Dr. Mary Nettleman and Dr. Carlos Del Rio, for helping us understand these infectious diseases. Astronomer Neil deGrasse Tyson shines a light on our place in the universe. Even with all our technology and the inventions that make modern life so much easier than it once was, it takes just one big natural disaster to wipe out all that and remind us that here on Earth, we're still at the mercy of nature. Until next time, stay healthy out there, people.
The arm bone's connected to the wrist bone's connected to the hand bone's connected to the telephone bone. Yes, it's time for you to call in your questions about bones and joints. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medical Care Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for our On Call with Prairie Doc is provided by generous support of Avera, Brookings Health System, and Fishbeck Financial Corporation.